Welcome to today's HealthLine webinar from the American Association of Kidney Patients, titled From Diagnosis to Treatment, a Deep Dive into Sepsis. Thank you for joining us today. My name is Jerome Bailey, and I am AAKP's Director of Patient Engagement and Advocacy. AAKP's HealthLine webinars fall under our Center for Patient Research and Education. We believe patient and care partner education is an integral part of treatment and protection of patient lives. And we work to ensure that the patient has a central role in research and the guidance that are designed to determine optimal approaches and strategies for providing healthcare services, assistance programs, and access to new products and services. We built this center with the latest polling and engagement technologies to ensure that kidney patients take a central role in informing the federal, academic, and private sector research shaping the next generation of healthcare services, assistance programs, and innovative new treatments. We encourage you to respond to our flash surveys and other engagement opportunities that you receive via email as a member of AAKP. As the oldest and largest independent patient-led kidney patient organization in the U.S., AAKP is proud to host this webinar as a service to our fellow kidney patients, family members and care partners, healthcare professionals, researchers, and policymakers. AAKP is a champion for full patient care choice, the protection of the patient-doctor relationship, and the elimination of barriers for patient access to available treatment options. Today, we are featuring a very important topic that many individuals may not normally associate with kidney disease, and that's sepsis. Infections and infection prevention efforts are a main focus for AAKP. AAKP was a founding member of the Centers for Disease Control and Prevention's Making Dialysis Safer Coalition and AAKP's very own Paul Conway, who's chair of Policy and Global Affairs, serves as a liaison to the CDC's Health Infections Control Practices Advisory Committee, also known as HICPAC. In collaboration with our allied partners at the American Society of Nephrology, we are also pleased to have AAKP's Ambassador Fiona McKinney out of the state of New York be a patient representative on ASN's Quality Assessment Improvement Work Group, whose goal is to disseminate infection prevention and dialysis safety tools to be used by healthcare professionals and patients. Without further ado, I'd like to get us started with today's webinar by introducing our first speaker, Marika Durning. Marika is a registered nurse with many years' experience in a variety of clinical areas, from postpartum to palliative care and hospice. She joined the Sepsis Alliance in 2010 and is responsible for the website content and outreach with public and organizations. No longer working clinically as a nurse, Marika is now a successful health writer and content provider. She has assisted in writing and researching nursing and emergency response textbooks and has written hundreds of articles for online and print outlets, such as the Oncology Nursing News, Memorial Sloan Kettering Cancer Center, Forbes.com, Costco Connection, Nursing 2013, Health Day News, Parade, and MSN Health and Lifestyle. When not working to educate the public on various health issues, you will probably find Marika in her sewing room where she designs and creates beautiful quilts among, almost nonstop. Marika, I will turn the presentation over to you.
Thank you very much. I appreciate it. Thank you for inviting me to be part of this. Sepsis is a very important topic, and as you will see as I go through the slides, I'll define it and we'll go into a nice discussion about how to possibly prevent it. So I called it Sepsis 101. It's a very basic presentation. I do need to read this disclaimer. So I need to tell you that this information is intended for educational purposes only. Sepsis Alliance does not represent or guarantee that the information is applicable to any specific patient's care or treatment. The educational content does not constitute medical advice from a physician and is not to be used as a substitute for treatment or advice from a practicing physician or other healthcare provider. Sepsis Alliance recommends users consult their physician or healthcare provider regarding any questions about whether the information might apply to their individual treatment or care. I'd like to welcome you to this presentation. I designed it to help explain the basics with the hope that you will take this home and spread it to your family members and friends and colleagues, because sepsis, as common as it is little known. So I'm going to talk to you about what it is and what it isn't, what causes it, risk factors, prevention, signs and symptoms, and how it's treated. First, what is sepsis? Sepsis, as I said on the slide here, is the body's overwhelming and life-threatening response to an infection that can lead to tissue damage, amputations, organ failure, and death. So what it is a systemic response to an infection. It's not an infection, it's your systemic response. I like to compare it to a bee sting. And if somebody is allergic to bee stings, they will get the sting, which is the local injury. But if they develop hives or trouble breathing or they start to swell, it's their body's systemic response to the bee sting. So sepsis is the systemic response to an infection. So what sepsis is not? Sepsis is not an infection. It's very common for people to say it's a blood infection or that they have sepsis in a certain spot. Like if they had, let's say they had an infection in their elbow, they might say they had sepsis in their elbow. It's not something you can have in a specific spot because, as I said, it's your body's total systemic reaction to an infection. It's also not blood poisoning. Now, I know we used to always call it that, and some people still use the term blood poisoning, but since it's not something that can be in the blood, it's not really an accurate term. So we're trying to discourage people from using that term, but I know that a lot of people still do. It's also not contagious. Some people are afraid, and I get a lot of emails from people asking if it's contagious, but what is contagious is the infection, or might be the infection, that caused sepsis. So for example, the flu is contagious. Two people can catch the flu at the same time. One might get sepsis, but not the other, because the sepsis can't be spread. It's your body's reaction to the infection. And it's not rare. I'll explain in a minute why it's not rare, but you will hear that a lot. You will hear people say, I've never heard of sepsis. I don't know anybody who's had sepsis, but chances are you do know somebody, or you did know somebody. So sepsis is a huge problem across the world. I'll focus on the United States, and it affects almost 2 million people every year in the US. So you can see what I mean about it not being rare. It causes an estimated 350,000 deaths in the US. That's a lot of people. Every 2 minutes, one person in the US dies from sepsis. And it's the #1 cause of death in hospitalized patients. It's 1 in 3 hospital deaths. So if you have a hospital reporting 900 deaths in that hospital, that means 300 of them are due to sepsis. The other 600 could be a mix of stroke, heart attack, trauma, any number of things, but 300 of them are due to sepsis. Now, about 1% of survivors of sepsis end up having to have some sort of amputation. It can be a finger, it can be a few fingers, it could be one limb, it can be multiple limbs. But 1% of that 1.7 million people will end up with some sort of amputation. Many survivors go on to live with organ dysfunctions, kidney failure, liver dysfunction. Their lungs might not work properly anymore, and they're going to need additional care. And as many as half of sepsis survivors live with what we coined several years ago as post-sepsis syndrome. And those are issues that last way beyond the actual injury caused to the body by sepsis. So a few more sobering statistics and facts. Deaths from sepsis outnumber a combination of deaths from opioid overdoses, breast cancer, and prostate cancer. Now, if you think about the news that we're hearing these days about the opioid crisis that we're having, and it's horrendous, there's way too many people dying from opioid overdoses, and they're getting all that news. I don't begrudge it. It's very important. But if you think that sepsis is killing that many more people, and we're not getting the news, we're not known. Sepsis is not known. It's also the most expensive condition treated in the United States. Almost $63 billion a year is spent on acute care on sepsis. And I'm just talking about in the hospital right then and there. I'm not talking about long-term care, rehabilitation, home care, things that you might need to buy to continue to live your regular life, lost wages. We're just talking about acute care costs. It's also the number one reason for readmissions to hospitals, and that is costing the system $3.5 billion a year. So it's not rare, and it's very expensive. So the reason we like to speak to the community, people like you, is because sepsis is a community problem. Many people who do know about sepsis, a little bit about sepsis, think that it's a hospital-related issue. But as many as 87% of cases start in the community. So we're talking about at work, at home, at school, while you're traveling. So you're not in the hospital, you're not in a facility. That is where it's starting. So that's why it's so important that people know what to look for and what sepsis is, because you can't advocate for yourself if you don't know if you don't know it exists, right? This is the really sobering number. As many as 80% of the deaths from septic shock could be prevented if sepsis was diagnosed and treated properly quickly. We can't prevent all sepsis deaths. We never will be able to. But 8 out of 10 people, if they had been diagnosed early enough and treated properly, could probably have been saved. For every hour that you're not treated, if you have severe sepsis, your mortality drops by 4 to 9%. So that is why recognizing sepsis early is so vital. So what causes sepsis? You have to have an infection for sepsis to occur. Now, sometimes you don't know you have an infection. There are people who develop sepsis and they find out later it was due to urinary tract infection or something like that. Well, I didn't have any symptoms. Sometimes the doctors never find the infection that causes sepsis, but you have to have an infection first. The most common type of infection that causes sepsis is respiratory. So we're talking pneumonia, influenza, COVID-19, anything like that. But it can be so if you can have bacterial infection, so dental abscesses, how many of us have had a dental abscess at some point in our life? After surgery, your wound might get infected. You could have strep throat. You can have a urinary tract infection. Those are caused by bacteria and can cause sepsis. You can have a viral infection, so influenza or viral pneumonia, viral meningitis, COVID-19. Again, any severe cases of COVID-19 was actually viral sepsis. Now, technically, fungal and parasitic infections can also cause sepsis, but it's not common, but it can still happen. So if you have an infection, it has to be taken seriously. So who's at increased risk? Anybody can get sepsis. A world-class athlete can get sepsis. The thing is, there are some people who are at higher risk than others, like for many other conditions, right? So we have adults who are older than 65 and the very young. Why? Because the very young, their immune system hasn't yet kicked into full gear. And as we age, our immune system starts to become less robust. Then there's people with weakened immune systems, and that can be for many reasons. You could be undergoing chemotherapy for cancer or receiving treatment for multiple sclerosis or psoriasis, rheumatoid arthritis, something like that. That can affect your immune system and make you more susceptible to catching an infection and getting sepsis. If you don't have a spleen, it's harder for your body to fight infections. If you have chronic illnesses like kidney disease, diabetes, COPD, they even include severe obesity in this category. And if you have severe injury, so for example, your skin is your biggest organ and it protects you. So if it's severely injured, especially with burns, you are much more susceptible to infections, which can lead to sepsis. Other risks include people of color. They tend to have higher risks of sepsis. If you live in a lower income community, you may not have access to medical care or quick enough access to medical care. If you have any invasive lines, and we're talking, ports, intravenous's, drains, tubes, urinary catheters. Anybody who's had surgery or an invasive procedure recently. And what I mean by invasive procedure is anything from inserting an IUD to getting an intravenous, anything that either introduces something unnatural into your body or pierces the skin. Patients who are hospitalized, and I would also add to that people who live in close quarters, because people who live in close quarters can spread infections more easily. And unfortunately, sepsis survivors are not more likely, but are at higher risk of getting sepsis again. So what are the symptoms? I've told you how terrible and scary sepsis is, but what are the symptoms? How do you know you have it? That's the problem. There's no one symptom for sepsis. They can be very vague, or they can come on very suddenly. So the people who have vague symptoms, they say, oh, I thought I had the flu, I had some sort of bug, I wasn't feeling well, my son came home sick from the daycare, so I thought he had what he had, and they thought they could go and sleep it off. Others were fine in the morning, and then by noon, they felt like they'd been hit by a truck. They felt so sick. So they can be very subtle and they can be very vague. And this is why we developed a program called It's About Time, T-I-M-E. So we developed Time because we wanted to make it easier for people to recognize a compilation of symptoms. So there's no one symptom, but if you have two or more of these symptoms, there's a chance that you might have sepsis, and you have to think sepsis. So T is for temperature, higher or lower than normal. Most people, when they're sick, when they have an infection, they have a higher than normal temperature, but there are some people that have a lower temperature. So that's something to keep in mind. I is for infection. Now, you don't necessarily have to have signs and symptoms of an infection. I like to tell this because you don't always know, like I said, you don't always know you have an infection. But is there a reason to think that you may have been exposed to something that could cause an infection? So were you recently gardening and did you cut yourself on a thorn? Did you recently have minor surgery or dental work? Did you have to pick up your child from daycare because they had a virus? You know, you might not think you have the virus, but there's the potential of an infection there. M is for mental decline. You can become very confused, very sleepy. Like I mentioned, all they wanted to do was go to bed and sleep. Now, some people say, well, my mother is already confused. She has dementia. But was there a change in that dementia? Was there a change in that confusion? Was she perhaps what we call pleasantly confused before, and now all of a sudden she's aggressive? Or the opposite, was she very aggressive before and now she's suddenly very docile? So was there a change in the mental status? And E is for extreme, extremely ill. Many survivors say it was the sickest I ever felt in my life. It was the sorest throat I ever had. It was the worst abdominal pain I ever had. So if you put together temperature, signs and symptoms of infection or the possibility of an infection, changes in mental status, and extreme, two or more of those symptoms, you need to think, I could have sepsis. Other symptoms that you might experience, you might be very cold, you might be shivering. A lot of survivors say, I've never been so cold in my life. Your skin might be clammy, your heart might be racing. If you have a blood pressure cuff at home and you like to take your blood pressure, you might find it's lower than normal. So sepsis is a medical emergency. Remember I said every hour your mortality rate can drop. It is very essential. We have that, just like with heart attacks and strokes, we have that golden hour. That first hour is so important. So if you suspect that you or your loved one may have sepsis, call 911. And you tell the operator, I think they have sepsis. It's important that you use the word because it puts a bug in their ear. You know, it's like, oh, okay, it's, you know, it just kind of guides them a little bit. Whether they pay attention to it or not, we don't know, but it has been shown that if you say the word sepsis, in many cases, it helps. Now, when you get to the hospital, either if you went through 911 or you transported the ill person to the emergency yourself, you have to, again, use the word sepsis, and you have to explain why you believe that person may have sepsis. Again, did they recently have surgery? Had they been sick? Had they had a cut or some sort of injury that broke their skin? And had they had sepsis before? You need to really convey that information to the intake people and repeat it, because doctors and nurses, some people find this very annoying in the emergency room. We ask the same questions again and again and again, but there's a reason for that. In the case of an emergency, we're not always thinking straight, and we might not always remember the answers to all the questions. So we're not testing you, and it's not that we don't remember, it's because it's giving you the opportunity to say, oh, I forgot to tell you. Okay, so that's why you're asked often the same questions again and again. It's not to annoy you, I promise you. So there are there's three stages of sepsis, but we call a fourth one too, because the first one is called SIRS, Systemic Inflammatory Response Syndrome. Now that technically isn't sepsis, because whenever you get sick, your immune system kicks in and it starts to cause SIRS. So if the infection goes away, the SIRS goes away. But if the infection doesn't go away, then it can progress to sepsis, which can progress to severe sepsis and then septic shock. So sepsis is the first stage, and that's when you're starting to see the signs and symptoms. Your body temperature is changing, you're getting the faster heart rate. In the emergency room, rarely are people at this phase kept in the hospital. You might be given antibiotics, probably by intravenous, because they also want to give you fluids, and you could be sent home with antibiotics and instructions to either come back if you're not feeling well, call your doctor for follow-up, or something like that. If the sepsis isn't treated and you develop severe sepsis, and that is when at least one organ in your body starts to not work properly. There's a dysfunction there. So you will have the symptoms of sepsis, and then you will have symptoms related to the body organ that is being affected. So if it's your kidneys, you will have low or no urine output. If it's your brain, you will become more confused. If it's your heart will really start to go out of whack. If it's your lungs, you will have a lot of difficulty breathing. So severe sepsis is your regular sepsis symptoms, in addition to some sort of organ dysfunction symptom. This is when you will be kept in the hospital. Most of the time you are admitted and given IV antibiotics and fluids, and hopefully trying to keep you from going into shock. Septic shock is the most severe form of the disease. People who are in the ICU with septic shock are often called the sickest people in the hospital. Now, the medical definition of shock is a blood pressure that's too low to sustain life. So you may hear that on TV or in the movies, he's in shock. That's because their blood pressure has dropped drastically. But when it's septic shock, it's the symptoms of sepsis, the symptoms of organ dysfunction, plus too low a blood pressure. And that is really the most difficult to treat. And the patients in the ICU who are in septic shock are getting all the attention. So how do we treat it? Again, that's the problem. Just like there's no one symptom, there's no one treatment for sepsis and septic shock. So what we have to do is we have to eliminate the source of the infection and increase your fluids to prevent dehydration, which causes a low blood pressure. So how do we eliminate the source of infection? Antimicrobials, so antibiotics if it's a bacterial infection, antiviral for virus if we have, antiparasitics, antifungals. That's the only way we can get sepsis to stop, is we have to get rid of the infection. The doctors may not know what kind of infection you have, so generally what they will do is order what they call a broad spectrum antibiotic, hoping to hit one of them. Then they're going to test either your blood, or if there's any pus or discharge or anything like that, and try and narrow down the actual infection so that they can target it better. But usually they'll just throw a general broad antibiotic at you and hope that at least it'll start the process. Other treatments you may see when somebody is in severe sepsis or septic shock: kidney dialysis if the kidneys are shutting down. They may need an oxygen mask if they're not getting enough oxygen. If they're having difficulty breathing, they may be put on a ventilator. They need medications if they are in septic shock, for sure. They're called vasopressors. They help raise the blood pressure. They might need other medications like analgesics to help relieve the pain. They may need surgery to remove the infection source. For example, we sometimes hear from people who had a hip replacement and the joint got infected, so they had to remove the hip. Sometimes the surgeons have to go in there and clean it. If it's an infection because it was a perforated bowel, they might have to go in there and clean it out to get the infection out. And there might be several other kinds of treatments. So they're dependent on the damage and the problems that the sepsis is causing. So they're not actually treating the sepsis, they're treating everything around it. So how do we prevent sepsis? The only way to prevent sepsis is to prevent infections. So like I said at the beginning of the presentation, we can't always prevent sepsis, just like we can't always prevent infections. Sometimes they just happen no matter what we do, but we can do our best to avoid infections as much as possible. So, of course, we start with hand hygiene. We really learned about during the pandemic for sure, but we need to keep that up. We need to wash our hands frequently, often. Even if you're wearing gloves, you're still supposed to wash your hands before and after wearing gloves. Very important are our vaccinations. Flu, COVID-19. Remember I said a lot of sepsis is caused by respiratory infections, but anything that your doctor recommends, you really should get it. Wound care, very important. If you have a wound, if you have a blister, don't pop the blister. That's nature's Band-Aid. I know it's very tempting, but don't do it. Make sure your scrapes and wounds are kept clean and dry. And then manage your risk factors. So for example, if you have type 2 diabetes, you are at high risk of getting foot sores and you might not feel it. So you need to check your skin to make sure you're not getting a sore. If you are, whatever your doctor tells you to help you manage your chronic disease, try your best to do that because it will lessen the risk of developing infections if you can get your chronic illness under control, if it's possible. So, like I said, we can't always prevent infections. So when we do get an infection, it is vital that we take it seriously. We can't just brush it off. So many women in particular who develop urinary tract infections, because they're so common, many will say, I'll flush it out, I'll drink cranberry juice. Infections are very serious. One of the first Faces of Sepsis stories I got on our Sepsis Alliance website was a young woman who died alone in Florida from a urinary tract infection that she didn't get treated. Okay, treat all infections seriously. So please contact your healthcare professional as soon as possible for guidance. If it's a serious infection, go to your urgent care clinic, an emergency department. Make sure that somebody looks at you and helps you manage the infection. If you're prescribed an antimicrobial, take it as directed and finish the whole course. Many people who take antibiotics start to feel better after day 4 or 5, and they figure, why should I take the last 5-6 days of it? I feel fine. You are feeling better, but the germs are still there. And if you stop taking them, then they're going to come back even stronger. And it also helps contribute to the antimicrobial resistance, the antibacterial resistance that we're having, because the more the bacteria are exposed to the antibiotics without killing them, the stronger they get and they become resistant to the medication. So please finish your medication. And don't take somebody else's antibiotics either. You may think you have the same infection, but it might not be the same one. And plus that person shouldn't have leftover antibiotics, right? They should have finished it. And so seek emergency help if you think you're showing signs of sepsis. It's so important. Just very quickly, just like heart attack and stroke, sepsis is a medical emergency. We have lots of resources at sepsis.org. We have downloadable resources, and you can also read a lot of the information on the website. Some of our resources are translated into Spanish. We now have almost 2,000 stories of people who have either survived sepsis or who have lost sepsis, and that is in our Faces of Sepsis section. And thank you. I really appreciate you listening to this, and I hope that I was able to give you some information that you will find helpful and that you will share to others.
Thank you, Marika, for sharing your expertise on sepsis, its causes, the treatments needed, and what might help after having sepsis. Let's now hear from Janice Sterling. Janice is an AAKP ambassador and transplant recipient from Florida. She has undergone various forms of dialysis, including peritoneal, in-center, and home hemodialysis. In her journey towards good health, Janice faced numerous challenges, such as a mastectomy, over 30 transfusions, and 2 years of IVIG treatment to lower her antibody levels and become eligible for a kidney transplant. Janice's aspirations extend beyond her personal journey. She is committed to raising awareness and promoting education about kidney disease and other possible complications. Her dedication lies in imparting knowledge and fostering a lifelong love for learning among children, women, chronic kidney disease patients, and anyone eager to expand their understanding. Janice, thank you for being with us today. I turn the presentation over to you.
Thank you, Jerome. I am so glad you invited me to come today. I remember when most of the things that the nurse spoke about really brought the feeling of when I was diagnosed with sepsis. I had a dentist appointment, and after my dentist appointment, I was on dialysis. 2 weeks later, I found out that I was sick, I was cold, I was having chills. I was in the dialysis center, and the dialysis nurse was like, Janice, you don't look well. And I said, I don't feel well. I'm sick all over. If you ever had the experience of sepsis, you are sick all over because your blood is all over your body and it runs all through your body. So every inch of your body aches. It's not like if you have or you stump your toe, you can say, oh, it's my toe is aching. No, your toe ache, your hands, your head, you're cold, you're shivering all over. So I was immediately rushed to the hospital, and they didn't know what was wrong with me. I had low blood pressure. I was practically almost dying. And the doctor my nephrologist started giving me vancomycin and tobramycin antibiotics. And they started running tests to see what was going on with me. And later they found out that I had a bacterial infection and it was sepsis. So it was just from getting my teeth clean when I was on dialysis. And so now, when you go to the dentist, please, if you're on dialysis or kidney transplant or any type of immunocompromise, make sure that you take your antibiotics an hour before you get your teeth cleaned, even just a general teeth cleaning. Make sure, because you do not want to experience sepsis. The next um, bout that I had was in sepsis was in 2010 when I was getting my fistula replaced. The doctor did a surgery to regraft my fistula. Where while I was in the hospital after the surgery, he noticed that something wasn't right. So he said, I need to go back in. And when he went in, I had a baseball mass of sepsis in my arm where he did my surgery. Thank God it didn't spread anywhere else. It was just a complete mass of sepsis in my arm, and he was able to remove it before it broke and carried all over my body, transferred over through my blood. So I've had sepsis twice, but that first time, that chills was it was just awful. It was awful. Any questions?
Yeah, how long was your hospital stay, and what was that experience like? At least for like, the first time that you were diagnosed with sepsis.
I was in the hospital for about 2 weeks. That was one of my longest stays in the hospital, other than my transplant was shorter. When I first went in, they didn't know what was wrong with me at first. So the first week was trying to figure out what is wrong. Why is her blood pressure low? And then trying to run test after test after test. And I was getting weaker and weaker and weaker until they just started pumping me with antibiotics. So it was a 2 week stay of trying to figure out what was wrong at first. Then once they realized what was wrong, it was the process of giving me the antibiotics to get my blood pressure back up to make me come alive again. So it was a 2 week long process.
So, and once you recovered, Janice, what kind of post-hospitalization care or support were provided to you in your recovery?
Well, after being treated round the clock in the hospital, when I was discharged, they sent me home with a dialysis nurse. I mean, a nurse, not a dialysis nurse, sent me home with a home care nurse where she would come in and continue to administer the vancomycin and the tobramycin so that I can continue to heal. So it was another 2 weeks process of getting treatment from a home healthcare nurse.
And one more question for you, Janice. What type of knowledge did you have about sepsis prior to your diagnosis?
I had no idea what sepsis was. I didn't know that going to the dentist would cause me to have sepsis. I had no knowledge, none whatsoever, none whatsoever. And that's why it was so. I mean, even in the hospital, they was like, Janice, what did you do? First, they had to wait to me to regain conscious and to become alert because I had a foggy memory. So it was a time where I had to run down my schedule what did I do? What did you eat? Where did you go? What happened? So that was a process in itself, trying to figure out what I had. So after that, once they figured out, I was still at home with a home healthcare nurse.
Well, thank you, Janice, for sharing your experience with sepsis. We appreciate you taking the time to be with us today.
You're welcome,
Uh,
Jerome. Thank you for inviting me.
few questions that people submitted when they registered for the webinar that I'm hoping our panelists can address. I'm going to start with Marika, and you kind of addressed this question already at the top of your presentation, but I'll ask it again. Is sepsis contagious?
We're very lucky in that sepsis itself is not contagious. It's because it's your own individual reaction to an infection. But what's important to understand is the infection itself depending on the infection, that could be contagious. So you don't have to worry about somebody in your home having sepsis. You won't get sepsis because that person has it, but you might get their infection if it's a contagious infection.
Thank you, Marika. This next question is for Janice. And Janice, you kind of talked about, the symptoms that you had. Can you go into a little bit more details about some of the symptoms you experienced, um, uh, as you were getting sick and, turned out to be sepsis?
Well, I was weak. That was the first experience. I was very weak, extremely cold. I mean, it's like a cold. It's not like you're in a refrigerator. Even when you put your hand in the refrigerator, it's not like a freezer cold. It's not like when you walk into a walk-in freezer. It's a cold where you can never get warm. It's like your body, because you got to think your blood is running throughout your entire body. So your entire body is cold. Your toes are cold. Your feet are cold. Your hands are cold. Your ears are cold. Everything is, it's like you're just chill, and you're steady trying to get warm, and you can't get warm. So that's when I knew something was wrong. I was at dialysis, and you already have a blanket, and because the building is cold. So but I was even extra cold, so they was trying to drink hot water, hot tea, trying to get warm, and it just couldn't get warm. And then my blood pressure was, feeling weak, a foggy head. You know what you did, but you kind of like not sure. So those are the symptoms you want to. The chills is one of the main things you want to make sure.
Yeah. Thank you, Janice. Marika, another question for you. And again, you kind of talked about this in your presentation. You mentioned that if you had sepsis once, there's a chance that you can get it again. Can you tell us a little bit why that's likely to happen again?
Well, there's so much we don't know about sepsis. It's very frustrating. But the re my theory, and what other people believe as well, is we don't know why one person will get sepsis and the other person doesn't if they have the same two infection, that they both have the same infection. So there's something in that person's body that caused their immune system to go into overdrive and cause sepsis. So the risk of them having sepsis again could be related to what caused them to have sepsis in the first place. It could be that for some reason they are more likely to get it. It's not because they are more immunocompromised than somebody else, as far as we know, but whatever caused them to have sepsis could be the reason why they might get it again.
Thank you, Marika. This next question is for Janice. Have you noticed any long-term effects since your diagnosis?
No, I haven't, but I have had, like I said, I had sepsis when I was had surgery on my fistula in the hospital. So maybe I wouldn't have had it again, or would have had it again. I just know that that second time I did have it, but it, like I said, it was contained in a ball, a nice sized ball, so it didn't spread throughout my body. But I'm very cautious. I always wash my hands. I'm always cautious of what I'm doing and things. So but I don't.
Thank you. Uh, our next question is for Marika. Um, and it says, I was once told I met the criteria for sepsis, but I wasn't septic. How do you know for sure if you have sepsis?
Therein again lies the problem. We don't really have one particular symptom. Now, Janice actually fit the time profile really well. You know, she had a possibility of an infection, right? The dental cleaning. A lot of people don't realize when you get your teeth cleaned, there can be blood, right? Because of the scraping and the cleaning, and that can introduce bacteria into your body, which can lead to sepsis. She had the fogginess, which would be the M for mental, and extreme. She was extremely, extremely cold. So she definitely fell into the at least two of the TIME. You know, but there is unfortunately no one way to know you have sepsis. It's sort of a diagnosis of exclusion. The doctors rule out other things. They'll draw your blood to see if you have an infection, if you have a lot of white blood cells, which can indicate that your body's trying to fight an infection. They'll quiz you like they quizzed Janice. You know, what did you do to try and figure out? But there is no one way of being able to tell. It's a thing of suspicion and just putting the puzzle pieces together.
Thank you. Marika, we have another question for you. What unique conditions do you find with sepsis in relation to home dialysis?
Well, any kind of home care puts you at risk for infections, right? Because there are unnatural openings to in your skin. There's changes. There's people coming and going. So there's in your home, there's a chance of people bringing in infection, bacterial infections or viral infections. So just the fact that you are receiving medical care at home can increase the risk of infection. So you have the fact that you have a chronic illness, which makes the dialysis necessary, and you're having the procedure done at home. So every time a dressing has to be changed, anytime a tube has to be changed, anytime anything is different, you are increasing the risk of introducing a bacteria into your body.
Thank you for that. And one last question for you, Marika. The question is, my husband had sepsis 3 months ago and is still not back to normal. How long does recovery take, and is full recovery possible?
That is it's a problem that we didn't realize when Sepsis Alliance first started and when I began with them several years ago. We coined a phrase called post-sepsis syndrome because we were hearing more and more about people who were being discharged home from the hospital having had sepsis and told, okay, you're fine, you're better, go on with your life. 50% of the people who have sepsis are able to do that. They go home, they recuperate, they go back to work, school, whatever their life is. Unfortunately, 50% don't. They end up with issues like chronic fatigue, chronic pain, hair loss, post-traumatic stress disorder, PTSD, depression. If they've had to have an amputation, then they have that to live with. There are so many, and nothing is really defined. We can't say who will develop post-sepsis syndrome and who won't. So some people will have a few weeks or a few months of issues and then slowly recuperate and then go back to their normal. Others won't. Some people end up with mental fog and can't go back to work because they can no longer concentrate. And the frustrating thing is we can't tell who will recover quickly, who will recover slowly, and who won't recover at all. It's an issue that they're really researching now, and it's actually getting more attention now because of long COVID. Like I said earlier in my presentation, severe COVID was viral sepsis. So it is starting to get attention because of long COVID. So maybe as they investigate long COVID more, we'll start to understand post-sepsis syndrome more. But the thing we have to understand is When you are in the ICU with septic shock, or even in the hospital with severe sepsis, your body is undergoing a severe, severe trauma. It's fighting to keep you alive. You're not getting any sleep because of the 24-hour care. You may have been in a coma, you may have been in a ventilator. So your body and your mind has gone through a lot. And it's, for some people, it's just much, much harder to recuperate from that.
Thank you, Marika Durning and Janice Starling. Your presentations were very informative today. Thank you very much.
You're
Thank
welcome.
you, Jerome. You're welcome.
If anyone watching has any additional questions for our speakers or about today's webinar that we were unable to get to, please send those questions to info@aakp.org, noting the webinar title in the email subject line. I'd like to close today's webinar with a few slides on additional resources that may be of interest to you. If you are not already a member of AAKP, we encourage you to join. AAKP offers free membership to patients and their family members, as well as living kidney donors. To become a free member, join online at aakp.org or by phone at 1-800-749-2257. To receive all the benefits of membership, please be sure to include your email address when signing up. As an AAKP member, you will be notified by email when opportunities arise where your opinions and experiences are needed to help inform innovative, advanced care and make a meaningful impact to improve lives. We encourage you to respond to our flash surveys and other engagement opportunities to help us elevate the patient voice and change the status quo for kidney disease care. You can also select to receive any of our 5 different electronic newsletters, and I encourage you to subscribe to our printed magazine, AAKP Renal Life. We also invite you to follow us on our blog and social media for all the latest news and announcements. AAKP is dedicated to helping kidney patients across the disease spectrum understand their condition and take control of their health care. We are proud to offer a variety of resources for both patients and care partners. By visiting our website at aakp.org and clicking on the AAKP store button at the top of the homepage, you can find a variety of educational brochures and online tools to order or download, including our Pocket Guide to Managing Kidney Disease or Coping, Living, and Thriving with Kidney Disease. We are excited to announce the 5th annual AAKP Fun Walk will take place virtually December 4th through 8th with an in-person walk in Tampa, Florida on December 9th. Registration for the Fun Walk opens soon. You can visit our YouTube channel to watch presentations on demand from our 2022 events and programs. Again, thank you, Marika Durnan and Janice Starling, for participating in today's AAKP HealthLine webinar. Thank you all for joining us today.